Good evening, everyone. I am Saurabh Agrawal, Vice President, Lupin Limited. On behalf of Lupin India, I welcome all of you for the ACC at Glance 2021. American College of Cardiology this year had a virtual event which happened last week. And today we are lucky to have our chairpersons and international faculty who shall give us an overview about what happened in ACC. And before we get into the scientific proceeding, I wish that you and your family members and all the loved ones are safe. And I must thank all of you for putting great efforts in fighting this second wave of COVID pandemic. And thank all of you for saving lives and helping people to achieve good health. With that brief, I would like to invite Lupin India Limited President, Mr. Rajiv Sibal, to give the opening address and kick off the session. So over to you, Mr. Sibal.
Thanks, Saurabh. Good evening, respected doctors. I hope you and your loved ones are safe and taking necessary precautions to fight the deadly second wave of COVID-19. I would like to thank each one of you for treating and taking care of your patients and supporting the country in its fight against the pandemic. With the number of active cases reducing in last couple of days, I hope the situation improves in coming months. At Lupin, we continue to extend our support to the medical fraternity by providing necessary safety gear and ensuring availability of medicines in every nook and corner of the country. We are together in this fight, and we shall always be by your side. Now, talking about today's evening, Lupin has always been a catalyst in fostering scientific and advanced medical knowledge by partnering with leading associations and universities. And so, we are proud to share with you highlights of ACC 2021, along with late-breaking trials, latest guidelines, and relevant topics of the clinical interest in the fields of heart failure, preventive cardiology, ACS, hypertension, and lipids, which will be discussed by global experts in the field of medicine. It is my pleasure to be a part of this scientific forum, which is graced by the presence of distinguished international faculties, Dr. Gregory Leib, Dr. Andrew Coates, along with country's leading QLs, Dr. A.B. Mehta and Dr. Singatuval. Lupin's pursuit for excellence in the field of medicine and better patient health outcome has helped it transform into a leading global pharmaceutical organization with strong footprints in the US, Europe, Asia, in addition to India. Lupin is one of the preferred partners trusted by the medical fraternity, professional bodies, and the peer organizations who partner with us for marketing ill-licensed brands and bringing them closer to the patients. Lupin is also a forward-looking organization which believes in bringing innovation in patient treatment and creating a conducive ecosystem. In the cardiodiabetes space, Lupin has consistently maintained leadership position by having a complete basket of necessary products and shall continue to contribute to the well-being of the patients in year to come. I would like to conclude by thanking you all and look forward to your active participation in today's event. Stay safe and take care. Thank you all. So over to you, Saurabh.
Thank you, Mr. Sibal, for setting the context about the whole program and also extending thanks from Lupin's side for all of you in terms of fighting this pandemic. Before taking much time, I have the honor of introducing the chairpersons for today's meeting, Dr. A.B. Mehta and Dr. Singatuval. I'll request to put up the slide for the introduction of Dr. A.B. Mehta. Of course, Dr. Mehta does not need an introduction, the senior most cardiologist of India. Currently, he is director at Department of Cardiology at Jaslok Hospital and a senior consultant in intervention cardiologist at Breach Candy Hospitals, Mumbai. He has been the pioneer in intervention cardiology with over 40 years of experience and credited with more than 35,000 angioplasties and more than 75,000 angiographies. He has done a lot of pioneering work in cardiac catheterization, angiographies in newborn in India, and way back in 1973, he was the first one to introduce bundle electrography in the country. Dr. Mehta has been the recipient of the prestigious Padma Shri Award in 2004. He, of course, is a great teacher and a professor. He has nurtured numerous cardiologists across the country, and today there are many students of his who is doing service to the field of cardiology and making patients have a better life in this field. He has numerous presentations, publications in national and international peer-reviewed journal. So thank you, Dr. Mehta, for being part of this program.
Thank you.
Thank you for having us here. Second, I would like to introduce Dr. Senkadavelu. Dr. G. Senkadavelu has immense record in terms of working on complex procedure and doing pioneering work on structural heart interventions, including TAVI, TAVR, and mitral clip. He has initiated and performed the first transcatheter valve replacement in 2015, and ever since then, he has immensely contributed to the development of TAVR. Currently, he is at Apollo Hospitals as a senior consultant and intervention cardiologist at Chennai. He has also contributed immensely for the medical education by training a lot of postgraduate students. He has numerous publications in the peer-reviewed national and international journal. He has authored more than 300 abstracts and various case studies across conferences around the world. Thank you, Dr. Senkadavelu, for chairing the session today. And it's our honor to have both the distinguished intervention cardiologists from India to be the chairperson for the evening. I am sure their insights from the India context and with the global experts that we have today on the forum, we should have a very engaging and interesting session about ACC at glance. With that brief, I would like to hand over the session to Dr. Senkadavelu. Over to you, sir. So you're on mute.
Yeah. Good evening to all. First of at the outset, I would like to thank Lupin India for having come across this ACC update, which is very important for cardiologists. And it's a proud privilege for me to co-chair this session with Dr. A.B. Mehta. Today, we have two eminent international faculties, and we will have two talks. At the beginning, I would like to request Dr. A.B. Mehta to say a few words, and then I will start introducing the faculty.
Well, I think very honestly, I'm excited and looking forward to a very exciting experience in the next 2 hours. The thing is that the Dr. Pamela Morris decided at the last minute that let us make it virtual because there have been restrictions in traveling in the various countries, and therefore this would be very difficult for people to attend the meeting, which I think this is one of the most popular meetings in cardiology arena. And therefore, because you all know, Senkadavelu and everybody, all of us, that our science is growing by galloping strides. It's impossible to keep up with the latest. And this kind of the virtual tour, which will be given by Dr. Gregory Lip and my other friend, and both of them will take us through the bird's eye view, or even sometimes I might think you might throw in important highlights will also be shown to us. And I think sitting in your own home or in an air-conditioned office, this is, I think, ultimate in luxury, that the knowledge is pumped in without you exerting even for a second. So I think this congratulations to Saurabh for a beautiful enterprise, and I think this experience will make me feel that I'm not missing ACC meeting, which I usually attend every year. Thank you so much.
Thank you, Dr. Mehta. So it'd be a proud privilege to introduce very eminent international faculties. We have with us Professor Andrew Coates. Can I have his slide, please? Yeah. So Professor Andrew Coates is a director of Monash Warwick Alliance, an academic vice president in Monash and Warwick universities, and he has have doctorates from Oxford and Imperial. He's been appointed as Viscount Royal Professor of Cardiology at Imperial College in 1996 and Director of Cardiology at the Royal Brompton Hospital and Harefield NHS Trust. He was also the Dean of Medicine at the University of Sydney in 2002. So he holds fellowship in several colleges, including the Royal College of Physicians, London. He has several publications, 15 government reports, 10 textbooks, 2 Cochrane reviews, over 500 peer-reviewed papers, and over 48,000 carrier citations. And importantly, he has been the editor-in-chief of the International Journal of Cardiology since 1999. And he has received a Lineker Medal of Royal College of Physicians and the inaugural Michael Pollock Award, the American Heart Association. So his research interests are in chronic heart failure and hypertension. So we are awaiting a grand academic feast from him. So the next faculty is Professor Gregory Lip. He's a professor of cardiovascular medicine from the University of Liverpool, UK. He's also a distinguished professor, Aalborg University, Denmark, adjunct professor at Seoul National University, Korea. He's also a writing committee member of various international guidelines, including anti-thrombotic guidelines of American College of Physicians and also the ESC guidelines on atrial fibrillation in the last few years. So it's a real privilege to have you both today. And first, I would like to invite Professor Coates, who will be telling us on the important aspects of heart failure in ACC. Professor Coates, please.
Thank you very much, Dr. A.B. Mehta and Dr. Sengavulu. It's my great pleasure to present to Indian colleagues, and my thanks to Lupin India for making this possible. I should share my screen. Let me just go back to the beginning. So I would like to present the highlights from the American College of Cardiology 2021. As has been mentioned, this was a virtual event, and we're getting used to that now. We do look forward to the day we can meet again. Here are my declarations. So the first study I'd like to present is a very important one called PARADISE-MI. This is a study of the angiotensin receptor neprilysin inhibitor, sacubitril/valsartan. And unlike the previous studies, which were all in the fields of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, this was in the post-MI setting. But it was post-MI with patients with poor left ventricular function and or transient heart failure. So it's really more like a heart failure trial than an acute coronary intervention trial. Many treatments that we've had that are effective in heart failure with reduced ejection fraction are also effective in the post-MI setting with large infarcts, and they prevent heart failure hospitalizations and death. They include the original ACE inhibitor trials, beta blocker trials, and MRA or mineralocorticoid receptor antagonist. The last effective treatment for heart failure, sacubitril/valsartan, had not been tested in this setting, so it was important we gain information on how it works in this regard. The historical trials for ACE inhibitors were the SAVE study, the AIR study, and the TRACE, and these were all 20 or 25 years ago. And they showed consistently that ACE inhibitors reduced all-cause mortality compared to placebo when given within the first week or so of a large myocardial infarction, with a odds ratio of 0.74, so about a 26% protection from the risk of dying. In addition, the ARB, valsartan, showed similar benefits compared to ACE inhibitors, so it appears that ACE inhibitors and ARBs are similar in this regard. Given that the ARNI, sacubitril/valsartan, combines valsartan with the agent sacubitril, a neutral endopeptidase inhibitor, it was important to compare its efficacy against that of ACE inhibitor, which was the gold standard. It clearly has the valsartan element with the extra additional effect of inhibiting neutral endopeptidase. The study design is shown here. Within half a day to 7 days of acute myocardial infarction with an ejection fraction equal to or less than 40% and or pulmonary congestion, plus one other high-risk enhancer, such as advanced age, low GFR, ejection fraction below 30%, atrial fibrillation, diabetes, raised killip price, killip class, prior MI, or STEMI without reperfusion, the patients could be randomized to either sacubitril/valsartan, 200 milligrams a day, or ramipril, 5 milligrams twice a day. Note that this is a high-dose ACE inhibitor, so it's up against clearly very full dose ACE inhibition. The primary endpoint was a composite endpoint of CV death, heart failure hospitalization, or outpatient development of heart failure. Secondary endpoint, CV death or first heart failure hospitalization. There were 5,669 patients randomized, so a very large and definitive trial. You see there are a few dropouts early on, 2,830 on sacubitril/valsartan, 2,831 on ramipril. The vast majority had good follow-up, and average dose achieved was quite good, with about 3/4 of the effective dose given. The primary endpoint is shown here. As you see, the curves separate within the first month or so. There were fewer events on sacubitril/valsartan, that's 338 compared to 373. The hazard ratio was 0.9, showing a 10% lower event rate in sacubitril/valsartan. Confidence intervals, however, just crossed 1, 0.78 to 1.04. Therefore, the p-value was not quite significant. So technically, this is not a positive trial, but it shows a very clear separation of curves. Early benefits continue to separate, and a very strong suggestion of clinical benefit. When we look at secondary endpoints, we see here major secondary endpoints. CV death or heart failure hospitalization, also hazard ratio 0.91 in favor of sacubitril/valsartan, but not conventionally significant. Heart failure hospitalization or outpatient heart failure unscheduled visit, hazard ratio 0.84, 16% protection, not quite significant. CV death, non-fatal MI or non-fatal stroke, not significant, hazard ratio 0.9. CV death, total hospitalizations for heart failure, MI or stroke, was a significant reduction, a 16% difference, p 0.045, and all-cause death, 0.88, a trend to a 12% lower mortality on sacubitril/valsartan. There were other pre-specified ways of looking at the data. The first were total events, first and recurrent. The clinical endpoint committee adjudicated primary events, and that showed a risk reduction of 0.79 relative risk, so a 21% protection from this definition of events, 539 events compared to 452, p-value 0.02, confidence intervals did not cross 1. Similarly, the investigators' reports of the primary endpoint also showed a significant difference with a hazard ratio of 0.85, p 0.01, 443 events compared to 516, so that 15% protection. So although the trial wasn't conventionally positive, there were a lot of ways of looking at the data which were pre-specified that did show significant benefits. Of course, it's important we look at adverse events, and we see that angioedema, which can be a concern with the combination of the ARB with sacubitril/valsartan with the neutral endopeptidase inhibitor, had a very low event rate and was actually numerically less than that of the ACE inhibitor enalapril. Serious adverse events were virtually the same. There was a slight excess of hypotension with sacubitril/valsartan, counterbalanced by a fewer number of cases of cough in sacubitril/valsartan compared to the ACE inhibitor. Other events, renal impairment, hyperkalemia, and liver abnormalities were similar. The reason this maybe was not a statistically significant difference was compared to the early trials in post-MI of ACE inhibitor or valsartan, where placebo event rates were over 30% mortality at 3 years with a substantial reduction. Now we're seeing such a better outcome after myocardial infarction with modern management of acute myocardial ischemia and STEMI with direct reperfusion and better post-MI care the event rates are dramatically lower, and you see both groups are having a 10% mortality rate at 3 years compared to a placebo rate in excess of 30%. Therefore, separation of the curves is more difficult because there are fewer events. In summary, in a vigorously managed enhanced risk AMI population, compared to active therapy with ramipril, sacubitril/valsartan did not result in a significantly lower rate of CV death, heart failure hospitalization, or outpatient heart failure requiring treatment. However, pre-specified observations of reductions in both the investigator-reported primary composite as well as the total and recurrent adjudicated events support the demonstration of incremental clinical benefits with sacubitril/valsartan. The safety and tolerability of sacubitril/valsartan in this AMI population was comparable to that of an ACE inhibitor, showing that the benefits of sacubitril/valsartan are extending to the post-MI setting, and that reinforces our view this is a major step forward in the management of heart failure in the broader context of heart failure-related symptoms. I'd now like to change over to another major development field, and that is the SGLT2 inhibitor group. And here we have results from sotagliflozin, which is another variation. This is an SGLT2 and 1 inhibitor. There are sodium glucose cotransport receptors in the kidney, which are type 2, and in the gut, which are type 1. So this sotagliflozin combines an extra mode of action compared to the more familiar empagliflozin and dapagliflozin. This was presented, and it was a result of 2 trials, both of which were stopped early because of funding difficulties in the COVID area, with a relatively small drug company being the sponsor of this agent, Lexicon. As mentioned, sotagliflozin has both SGLT1 and SGLT2 inhibition, which has effects in the gut as well as in the kidney, and the gut receptors are not affected by the level of renal function. The pooled data of these 2 trials, these were both trials in type 2 diabetes. There were no non-diabetic patients. SCORED trial was patients with CKD, and the SOLOIST trial was patients with heart failure. But unusually, this trial, SOLOIST, included patients with both HFrEF and HFpEF, and also they were recruited during the acute hospital admission. This analysis showed the effect on total CV death, heart failure hospitalization, or urgent heart failure visit in 739 patients who had HFpEF, defined as ejection fraction 50% or higher. Now, we know that prospectively no trial of HFpEF has shown a significant benefit, and this, again, was not a specific HFpEF trial. It just included significant numbers of patients with HFpEF. You see there the effect on this composite endpoint had a hazard ratio of 0.63, so a 37% reduction. There were 11.6 events per 100 patient years protected, and the treatment patient years to avoid one event was 9. You see there the clear separation of curves separating quite early. So this is supportive evidence that this interesting class of drugs, albeit a slightly different agent, is working in the acute heart failure, acute decompensated heart failure setting, and possibly appears to have benefits extending into heart failure with preserved ejection fraction. When the SOLOIST trial, which was heart failure, was combined with a SCORED trial, which was chronic kidney disease, there were, of course, a range of ejection fractions. It's a significant effect. For ejection fractions below 40%, the hazard ratio is 0.8, statistically significant. Between 40 and 50%, what we now call heart failure with mildly reduced ejection fraction or mid-range ejection fraction, the hazard ratio was 0.57. P-value also significant, 0.002. And in patients with ejection fractions equal to or above 50%, hazard ratio was 0.67, P equals 0.006. With the warning that these trials were both stopped early, they both were smaller than had intended, and they were restricted to type 2 diabetics, these results reassure us that the benefits we see with the 2 better established SGLT2 inhibitors, dapagliflozin and empagliflozin, seem to be extend to a third in the class and might indicate a class effect for this interesting new group of drugs. showing benefits across a range of ejection fractions and a range of different clinical settings. When we look at the results shown here, divided by important subgroups, gender, you see a consistent benefit, but independently significant in female patients with ejection fractions above 50%, the true HFpEF population in women, which is a group that's been very difficult to prove effective treatments in. Also, in 4,500 patients with a history of heart failure, we see significant benefits in ejection fractions 40-50% range and above 50% range as well. In conclusion, sotagliflozin robustly and significantly reduced the composite of total cardiovascular deaths, hospitalizations for heart failure, and urgent visits for heart failure across the full range of ejection fraction, including patients with heart failure and preserved ejection fraction. As well, in on-treatment analyses, sotagliflozin demonstrated a significant reduction in cardiovascular death. They're the first randomized data from pre-specified analysis of clinical trials to show a significant effect of this therapy on heart failure with preserved ejection fraction, and a consistent significant also in women. A third trial is also an important new analysis of another major trial that's come out in the last 12 months, and that's GALACTIC-HF, and that's a trial of an agent with a totally different mode of action. This is omecamtiv mecarbil, which is a direct myosin activator. This was presented by John Teerling. The background, omecamtiv mecarbil is a selective cardiac myosin activator, or a myotrope. It improves cardiac structure and function and decreases heart rate and N-terminal proBNP in patients with HFrEF, but it does it by a completely different function. It stabilizes the cross bridges in the contractile apparatus, which strengthens and lengthens cardiac contractility without increasing myocardial oxygen consumption. In the GALACTIC-HF trial, omecamtiv mecarbil improved the primary endpoint of heart failure events or cardiovascular death in patients with HFrEF, ejection fractions equal to or below 35%. The question that was asked is whether the baseline ejection fraction modifies the treatment effect of omecamtiv mecarbil. One might expect that, given that the principal mode of action is actually to increase cardiac contractility, the degree of reduction of contractility may be important determinant of response. Trial design, as a reminder, was a 1-to-1 randomization parallel group study compared to placebo on the background of standard of care, compared to omecamtiv mecarbil, along with standard heart failure therapy. Starting dose 25 milligrams once a day, raised to either 37.5 or 50 milligrams once a day, based on measurement of omecamtiv mecarbil levels in the blood. You'll remember the primary composite endpoint was a significant reduction in the composite endpoint of time to first heart failure event or cardiovascular death, hazard ratio 0.92, showing 8% reduction, significant effect, p equals 0.025. Curves separating early continued to be apart during follow-up. There were some interesting subgroup results, which was pre-specified, and one of the most important was ejection fraction. And here you see the benefit. To the left is an improvement of omecamtiv mecarbil, and you see a much greater effect, independently significant, for the baseline ejection fraction to equal to or below median, which was an ejection fraction of 28%. There were other subgroup analyses that also showed a similar direction, such as more severe NYHA class and higher levels of N-terminal proBNP. So it does appear that the more severely affected patients are getting, if anything, a slightly greater effects. When looking at baseline characteristics by quartile of ejection fraction, we see here comparing quartile 1 with the lowest ejection fractions, with quartile 4 the highest ejection fractions. The age is very slightly different, slightly younger in the more severely affected patients. There was a different male-female ratio, more males, and there was some racial differences. In degree of etiologies, there was less likely to be coronary artery disease, less likely atrial fibrillation or flutter, less likely hypertension. When we look at the results of omecamtiv mecarbil in blue or placebo in black, The difference between these curves is the treatment effect. And you see here, there's a strong trend to be associated, the treatment effect, with the baseline ejection fraction. You see that there's very little effect when the ejection fraction is close to the upper limit of 30 to 35. The curves continue to separate because the placebo composite endpoint rate goes up dramatically, whereas that of omecamtiv mecarbil is flattened, showing a much bigger benefit, treatment benefit, in very low ejection fractions, right down to almost single figures, as shown here. If we now look at the absolute relative treatment effect of omecamtiv mecarbil compared to placebo on cardiovascular death, you see also a similar analysis. The treatment effect is also better in the low ejection fractions, but perhaps the difference isn't quite so steep as it was for the composite endpoint. But it does look as if most of the treatment benefit and mortality is occurring in the lower ejection fractions. In conclusions, in patients with HFrEF, omecamtiv mecarbil reduced the primary composite outcome, first heart failure event or CV death. Treatment effect increased with decreasing ejection fraction, but there was no difference in serious adverse ischemic or arrhythmic effects compared to placebo across the range of ejection fractions. Also, no adverse effect was seen on blood pressure, heart rate, potassium homeostasis, or renal function. So this gives another possible treatment advance in the future when this drug is approved for use in multiple countries, and particularly it's advantageous because it's not a blood pressure reducing drug. It appears to have a very attractive mode of action for poor cardiac contractility, and its treatment benefit appears to be largest in patients with the lowest ejection fraction, perhaps those in most need of new treatments and remain symptomatic and disabled despite optimal guideline-directed medical therapy. Next is a completely different approach, which is a novel agent, pirfenidone, in the Pirouette trial presented by Chris Miller from Manchester, United Kingdom. Pirfenidone is an orally bioavailable small molecule anti-fibrotic agent, and it's licensed for idiopathic formulary fibrosis. It interferes with the fibrotic process because it inhibits the synthesis and secretion of TGF-beta1. It inhibits fibroblast proliferation and reduces its function and pro-fibrotic pathways, but it has no hemodynamic effect. The hypothesis was in patients with HFpEF who are known to have myocardial fibrosis. If we could detect and recruit patients with high levels of myocardial fibrosis, pirfenidone would, the hypothesis says, lead to regression of this fibrosis, and that might improve cardiac function and clinical status. Regression of myocardial fibrosis may be associated with improvements in cardiac structure and function, fluid status, and quality of life. The design is shown here. First of all, there was a cardiac magnetic resonance assessment for the degree of myocardial fibrosis, and a measurement was made of extracellular volume. If it was less than 27%, they entered a registry. If this extracellular volume detected by magnetic resonance was equal to or above 20%, 27%, randomized to pirfenidone versus placebo, a relatively smaller study of 94 patients, and then 12 months repeat CMR looking at the extent of myocardial fibrosis. As you see here, the amount of extracellular volume in the pirfenidone group went from 29.5% to 28.6%, so a small reduction, whereas in placebo group it increased from 30.7 to 31.1. The difference was a between-group difference of 1.2% in myocardial extracellular volume or fibrotic tissue. Now, that may not sound a lot, but if that's 1% of the myocardium changing from fibrosis towards more active tissue, that may be an important difference. It was highly significant, p equals 0.009. You see here that the levels went down in terms of log N-terminal proBNP. You see a difference there with lower levels on pirfenidone, p.02 compared to placebo. Serious event rates were not important and similar between pirfenidone and placebo, and there was no consistent pattern there, no difference in cardiac adverse events. Conclusion, this is a first trial that suggests a way of improving heart failure treatment by looking at the biological pathways and novel pathways. The results provide support for the concept that extracellular matrix may be important in heart failure, particularly HFpEF, and could become a new therapeutic target. The magnitude of this extracellular volume change would be associated epidemiologically with between a 10 and 28% reduction in heart failure hospitalization and death if the results of observational studies could be translated into the interventional trial perspective. Therefore, it's attractive to this may be a future agent for a larger scale HFpEF trial. Conclusion: pirfenidone reduced myocardial fibrosis. It may have a favourable clinical effect in HFpEF, but requires larger studies, and further trials are likely to be seen in this agent looking at clinical effectiveness and safety in HFpEF. Next, something which I've had a particular interest in for many years, and that's exercise rehabilitation in heart failure. And this was a very pragmatic trial presented by Delaine Kitzman, Chris O'Connor and colleagues. It was called REHAB-HF. It was an innovative physical function intervention for older patients during a hospitalization for acute decompensated heart failure. The background and rationale is that acute decompensated heart failure is the most common discharge diagnosis in older persons. These people suffer poor quality of life, frequent rehospitalization, very high mortality, and frequently loss of independence and inability to go home to live by themselves. There's a high rate of nursing home admission. Most intervention trials in this setting have been neutral, and very few patients have been recruited into pharmacological trials. Outcomes may be driven partly by mechanisms being overlooked. A pilot study of this trial showed a marked improvement could be obtained in physical function, particularly balance, mobility, strength, and muscle endurance, if patients could be trained. And importantly, more than 90% of patients recruited in this pilot study had the definition of frailty or pre-frailty, showing they had significant multiple comorbidities, very impaired function, and very weak and very poor ability to self-care. The intervention in REHAB-HF was a specially designed and tailored exercise rehabilitation program, one-to-one sessions conducted by a trained exercise therapist. There was a stratified grid for each domain to improve the function of skeletal muscle, particularly targeting muscle balance, mobility, and strength before endurance training. So these patients were assessed for their ability to exercise, and they were recruited with very low levels of exercise tolerance, and they had a specially designed exercise rehabilitation. It was a multi-domain rehabilitation intervention that was assessed and started during hospital admission. 1 to 7 days after discharge, there was a facility-based rehabilitation sessions 3 times a week that then carried on to the home environment with home exercise twice a week. It was then a maintenance phase of home exercise unsupervised 5 times per week for 6 months. The primary outcome was a thing called the short physical performance battery. That isn't a common endpoint for heart failure trials, but it's a common endpoint for elderly trials, sarcopenia, which is a condition of muscle wasting, and for very frail patients, particularly patients with cancer cachexia and similar conditions. At baseline, the SPPB was very low. This is a score made up of simple physical function tests, such as climbing 10 steps, standing up from a chair, and being able to stand on 2 feet without wobbling or falling over. There was a big improvement with the intervention, showing a big clinical increase from 6 points to 8, and a difference between the control group and the intervention group of 1.5 units. It is considered that the minimal clinically important change in this measure is 0.5 units, so the treatment effect was indeed very large and very highly statistically significant. Other outcomes measured at 3 months included 6-minute corridor walk test, which of course is a more commonly used heart failure endpoint. That showed a significant improvement of 34 meters. There was a reduction in the Fried-Frailty criteria, showing protection from frailty. There was an improvement in KCCQ, a common heart failure questionnaire, and this improvement was larger than many recent drug trials, with a plus 7.1 unit difference in KCCQ, and also a reduction in the severity of depression as estimated by the geriatric depression scale. So in summary, diverse, frail, older populations with a very high comorbidity burden. These patients on average had more than 5 separate comorbidities. They had markedly impaired physical function and quality of life, yet they could have excellent adherence to the exercise intervention program. This intervention produced a large, significant improvement in the short physical performance battery that was uniform across pre-specified subgroups. And there was a large, clinically important difference in 6-minute walk test difference, quality of life scores, KCCQ, as well as depression and frailty scores. Next, this one caught my eye, and that was a different type of intervention. This was an intervention into hospitals rather than patient level. It was the effect of a hospital and post-discharge quality improvement scheme on clinical outcomes in patients being looked after for heart failure with reduced ejection fraction, called the CONNECT-HF. This was a cluster randomized study. In other words, you take a large number of hospitals, and instead of randomizing individual patients, you randomize hospitals into some hospitals that have the intervention group and other hospitals that don't have the intervention. The rationale for this was that many reports had shown that clinical practice guideline implementation strategies should be recommended, and that the advice would be that you need audit programs to get feedback to improve processes and systems within hospital. And all of us working in a hospital environment know that our systems can be improved. It was felt that education and mentorships to the hospitals by a special academy might improve the level of quality of care, and that may translate into patient benefits. Study design show here hospital enrollment, 161 patients, treating 5,647 patients, ongoing heart failure treatment according to local care patterns in clinic, and a follow-up for 12 months. The only intervention was the mentoring and training of the hospital staff to improve their systems. The primary outcome was heart failure, rehospitalization. As you see there, a composite endpoint. Sorry, I'll just go back. Or death. The curves didn't really separate very well. There was a trend in direction for the intervention of 8%, hazard ratio 0.92, but not statistically significant. The composite quality score did show very slight difference, but yet again, trending in the right direction, but not statistically significant. So inclusion, a very interesting cluster randomized trial of hospital interventions, treating patients after HFrEF. The hospital post-discharge quality improvement intervention did not meaningfully improve heart failure outcomes or care above the quality improvement efforts. The problem with this type of trial is that hospitals that volunteer to enter such a program have already improved themselves, and the mere participating in the trial leads to greater attention to the quality system. So probably the control group is not a true real-world practice level of improvement that everyone effectively was improved just by entering the trial. Clinical implications, there are still major gaps in guideline-directed care, low rates of ACE inhibitor ARB ARNI use, evidence-based beta blockers and MRAs. We need new approaches. This one, unfortunately, we couldn't get the evidence that this was a significant benefit. However, we do need to address further evidence and effort towards improving our systems. Lastly, I'd like to talk about some further discussion of the new universal definition of heart failure. This was presented by my colleague, Beacon Boskert, who was the president of the Heart Failure Society of America when I was president of the Heart Failure Association of Europe. We developed and worked towards a universal definition and classification of heart failure, and this was a multi-association scheme. So we had the Heart Failure Society of America, the Heart Failure Association of the ESC, Japanese Heart Failure Association, Canadian Heart Failure Association, HFAI, Heart Failure Association of India, Cardiac Society of Australia and New Zealand, and the Chinese Heart Failure Association, all working together towards this new definition. It was published simultaneously just a month ago in the European Journal of Heart Failure and the Journal of Cardiac Failure, which is the official journal of both the American and Japanese societies. It involved 33 experts across a range of countries around the world, 10 from the Asia region, 1 from Australia, 13 Europe, 13 North America, as shown. It was a truly international effort. The new universal definition was somewhat simplified, but also it was made more approachable so non-experts can use it. And we synthesized the definition down to symptoms or signs of heart failure caused by a structural or functional abnormality and corroborated by at least one of the following: either elevated natriuretic peptide levels or objective imaging evidence of cardiogenic pulmonary or systemic congestion. So for the first time, we had elevated natriuretic peptide levels to being a possibly sufficient evidence combined with symptoms and signs and cardiac abnormality to diagnose heart failure. This makes the diagnosis of heart failure easier and more similar for clinical trials, regulatory purposes, documentation of hospital discharge summary, and means multiple types of physician can now reliably make a heart failure diagnosis. The more wordy version is shown here with some of the definitions of what a significant structural or functional cardiac abnormality would be in terms of ejection fraction, chamber enlargement, E to E prime ratios, or moderate severe ventricular hypertrophy or valvular obstructive or regurgent lesions. And what you might need to corroborate this, either the elevated natriuretic peptide levels, and the paper goes into details of what levels might be, as well as chest X-ray or elevated filling pressures by echocardiography or hemodynamic measurement. Importantly, we also looked at the staging of heart failure, and we'd gone back to the ACC-AHA stages, which of course had a 4-stage system, stage A to stage D, but these were all cause heart failure, whereas we came to the conclusion that heart failure was a symptomatic condition. Therefore, stage A and stage B are not heart failure. They are being at risk for heart failure or being pre-heart failure. Heart failure is restricted to stage C and stage D. And of course, these stages overlap with the more commonly used NYHA classes 1 to 4. Within stage C, we have heart failure that may persist or heart failure that may apparently improve, but the heart failure does. And advanced heart failure is stage D, and of course that then can be further separated by things such as the INTERMAC score. The important feature is with guideline-directed medical therapy and intensive risk factor modification, a patient can be pushed backwards towards the left to earlier stages of heart failure. So we defined other clinical trajectory terminologies for heart failure. New onset or de novo heart failure is someone who develops heart failure with no prior history. Worsening heart failure was where you get worsening signs, symptoms, functional capacity, or requirement for escalating levels of therapies, including possibly hospitalization. Improving heart failure is when everything is going in the right direction. Persistent, as the name suggests, is when you get ongoing symptomatic limitation. And remission is resolution of symptoms and signs with resolution of previous structural or functional heart disease after a phase of symptomatic heart failure. We said we should not use the word recovered because we cannot say these are ever completely normal. Instead, we use heart failure in remission, and we should not use stable for these patients because heart failure with ongoing symptoms and signs is not stable. Instead, we prefer the terms persistent. These are important because one relatively small study looked at patients who apparently had improved heart failure on therapy and then considered they might have recovered dilated cardiomyopathy, but when pharmacological treatment was withdrawn, 40% of patients had a redevelopment of heart failure within a short period. Therefore, this improvement in function we see in occasional patient represents remission rather than permanent recovery. We believe that the stages will be important to get a larger group who remain at risk of heart failure but do not have and never had heart failure. And we now have this pre-heart failure stage of asymptomatic LV dysfunction in which treatment with pharmacological treatments is justified to improve outcomes and delay heart failure. We now have a new ejection fraction-based classification of heart failure. Reduced ejection fraction is reduced ejection fraction heart failure, HFrEF, is heart failure with LVEF equal to or below 40%. Heart failure with mildly reduced ejection fraction, HFmrEF, is ejection fraction between 41 and 49%, and HFpEF is restricted to heart failure with ejection fractions equal to or above 50%. We also introduced the term of heart failure with improved ejection fraction, which is heart failure where there was a baseline ejection fraction to below 40%, and at least 10-point increase from baseline, and a second measurement now above 40%. In summary, we standardized the definition of heart failure to make it more easy to use, proposed a new revised classification of heart failure: at risk, pre, heart failure, and advanced, stratified and made clear the ejection fraction classifications, and talked about clinical trajectories of persistent rather than stable and in remission rather than recovered. Lastly, I'd like to encourage you to sign on for our heart failure meeting coming up at the end of next month, 29th of June to 1st of July. The faculty will be in Florence, the first time faculty have come together for a long time. Audience is invited to register and come and view the sessions online, including the first public airing of the 2021 ESC Heart Failure Association Guidelines for the Management of Heart Failure. Thank you all very much.
Thank you, Professor Coates. That was an excellent overview of the heart failure trials presented in the ACC. So I think we're very interesting. You'd like to discuss the 4 trials, particularly starting with the Paradise AMI trial. I think that's one of the important trials present in the ACC. So it was very clear from the trial that definitely Ramipril has a huge benefit, which is cheaper alternative, which is definitely should be given for all patients. And though the adding ARNI didn't show expected negative benefits, huge benefits, it really showed a marginal benefit. Why do you think it showed only a marginal benefit compared to the other ARNI trials?
I think the main difference, and I'll be looking forward to Greg Lipp's talk because I think he might also touch on this trial. I think the main difference is if you look back at Paradigm, it was up against enalapril 10 milligrams BD, and maybe we feel that enalapril 10 milligrams wasn't the totally best possible ACE inhibition. So sacubitril/valsartan was up against something that was good, but maybe not perfect. But up against Ramipril 5 milligrams twice a day, that's a big dose of a very effective ACE inhibitor. So one difference might be that the comparator was just extremely good. So although there was an extra benefit, it needed to be much bigger. The second difference, as I showed you, was that in the days when we did the first post-MI ACE inhibitor trials, placebo mortality rates were 10% or more per year. Now they're about 3 or 4% more a year. So there's just less of a residual mortality in which we have a chance to affect. Lastly, there's also the play of chance. When you have a p-value very close to 0.05 and it doesn't quite get there, you never know whether you toss the dice again and it would have been significant. But I think it's reassuring that it was absolutely a strong trend, consistent with other trials. And if you have a patient in the post-MI setting and you're convinced they're going to develop heart failure or they already have it, then there's a logical argument to start straight with a ARNI rather than go to the ACE inhibitor and then wait 3-6 months.
Based on this trial, do you think the practice will change to start ARNI yearly after acute MI?
I think it gives a lot more assurance that there's no risk with starting an ARNI early during an acute admission. We've had some smaller trials with acute decompensated heart failure. We've now had a very large trial with post-MI heart failure. A lot of these patients had heart failure, and not only was it safe, it was very close to being significantly beneficial. So I think it will encourage doctors to use more acute administration of ARNI as a first step. I'm not saying now that guidelines will say you have to do that, but clearly I think it's now very possible to do that, and many doctors will be convinced.
Dr. Mehta, you have any questions?
Well, yeah, I have a small question. Dr. Coates, in this material and method, was the differentiation or a distinction was made with the people who have an open artery after myocardial infarction, be it thrombolysis or be it angioplasty, and those who have had a not open artery? This particularly I'm asking because the remodeling of the scar in the heart in general would make a difference in the outcome of heart failure.
Yes, they did do. It was one of the pre-specified subgroups was effective opening of the artery, and it wasn't a significant difference, but there was a trend. If I remember correctly, I haven't got it in front of me. I think the patients who had the open artery did slightly better with sacubitril/valsartan. I'd better double check with that one, but it wasn't an important difference, so it wasn't the reason for the absence of a result.
Okay.
So this trial clearly, though it fell short of producing a significant benefit, it showed good safety of ARNI when we started early after acute MI, as early as 6 hours post-MI. So that is a good thing which we've learned from this trial. Probably we need more and more data and information to start in acute MI till it becomes a standard practice.
Yes, I'm just comparing PCI use at baseline. It was a significant statistical interaction, but we never know whether they're reliable. Patients who had PCI at baseline had a hazard ratio of 0.81 that was nominally significant, whereas those who didn't had a hazard ratio of 1.38. So sacubitril looked better in those who had PCI.
Okay. Thank you.
Okay. So now let's move to the other interesting trial, the sotagliflozin trial. I think this again evoked a lot of interest because we know that SGLT2 inhibition has shown a lot of benefit with a number of trials. Now we have also SGLT2/1 along with SGLT2 inhibition, and particularly in heart failure with preserved ejection fraction, which is really interesting. So I think this is going to definitely change our practice, definitely. So what are your views about the change of practice?
Yes, it's a tricky one because these trials stopped early. There are a lot of reasons for that, but the sponsoring company wasn't one of the major pharma companies, and their partner pulled out of the agreement. So they stopped the trials early. So neither reached the endpoint that they planned for. So there's always a slight uncertainty whether this was a fully prospective trial expected to have these results. Having said that, the SCORED trial was very large. There were more than 8,000 patients. SOLOIST WHF was a smaller trial, but it still had a very significant result. What was different about this is there are many things that were different. A, they were all diabetics. Unlike DAPA-HF or EMPA-reduced, it didn't include non-diabetics. B, the agent's different. It's an SGLT1 and 2 inhibitor. And C, for SOLOIST, it was actually started during the acute hospital admission. And even a fourth difference, it included both HFrEF and HFpEF. So what do we make of that? Is SOLOIST proof in its own right? I think it's very close to being proof. A purist would say, no, because the trial was smaller than it should have been, we can't be absolutely certain. Does it prove that there's a class effect? Yet again, it's a little bit difficult to say because it's a slightly different agent. We have 3 agents. We haven't got 4 or 5, but I think it's more and more looking like the SGLT2 inhibition itself is beneficial in heart failure, irrespective. Lastly, does it mean that we can start other SGLT2 inhibitors in the acute hospital stage? I'd say clinically, that's looking very likely. And I personally, as my own practice, would start it during acute admission. Yet again, if you're a purist, you'd say we haven't got a precise trial gone to its full plan size with that motion, with that plan in place. Lastly is the easiest one. Is it proof for HFpEF? In that one, I'd say it's not proof because it was a subgroup. It was small numbers. However, it's a very exciting prospect that it might be confirmed in a prospective trial.
Dr. Mehta?
No comments. Go ahead.
Okay. So how is the tolerability of sotagliflozin as compared to the other agents, particularly related to genital infections?
It's similar. There's a small excess of genital infections. We know that the side effects of there was also in the ACC a very good, important overview, very large registry of many patients on SGLT2 inhibitors, a variety, and the only consistent adverse events were from genital and urinary tract infections and a small excess of diabetic ketoacidosis in the diabetic patients. There was no excess of amputations, bone fractures, and significant hypoglycemia occurring in patients without diabetes. So some of the concerns have been allayed, but we do need to advise patients about care and hygiene to avoid the effects of genital infections, which is a side effect of these agents.
In India now, along with aldosterone inhibitors and along with beta blockers, both this ARNI and SGLT2 inhibitors have become very cornerstone for heart failure management. So in the benefit of our viewers, can you tell us when to initiate ARNI and then the SGLT2 inhibitor?
Well, we're all waiting for the next guidelines to come out. The only people that have put out guidelines so far is the Canadian. The European guidelines will be presented for the first time, as I mentioned, on June 29th. And everyone's waiting to see what's the order in which guidelines recommend treatments. I think people now are suspecting that we will possibly slightly change direction. And I think a lot of experts are now talking about 4 foundational treatment groups: the ACE inhibitor, ARB, ARNI class, and the discussion we've had earlier, whether you could start with ARNI or go to ACE inhibitor and then convert, the beta blocker class, the MRA class, and the SGLT2 inhibitor class. My personal practice will now be to start those agents depending on the patient profile. So if they're congested, then you might want to start with an ACE inhibitor stroke ARNI. If they're not congested, you may want to start with a beta blocker. You'd very rapidly want to add other agents. And when it comes to the SGLT2 inhibitors, you've got to take into account these agents are relatively much easier to use. They don't need slow up titration. They're a single dose. They're very easy. We know they're safe to start during a hospital admission. And because they have very much smaller effects on blood pressure, no effect on heart rate, to be honest, for those agents, you can almost start them at any stage because you can do it just quickly, start it one day and they're on treatment straight away. So I think a lot of people are going to use SGLT2 inhibitors at any point during the clinical sequence, including early on and including even starting them a day after they've started something else.
There's a question from the audience. Is there any GI side effects of sotagliflozin?
Well, nothing came up in these trials. It's clearly possible. Any drug can have GI effects, but nothing came up substantially related to the GI SGLT1 effects. Maybe we need larger trials to be certain about that, but certainly it's not a concern.
Okay. So there's another question about Paradise MI. So which subgroup Paradise MI was most benefited with ARNI? I think you already mentioned that those patients who had PCI.
Those people had PCI, and the other group, there's a bigger benefit in those aged above 65 years. They were the 2 subgroups where we got better effects. There was also a better effect in those patients with lower blood pressure levels. And interestingly, patients with atrial fibrillation, but the numbers were pretty small in that. And I know that's Greg Lipp's special interest, so maybe he could comment on that. They're really the things that stood out. STEMI patients had slightly better efficacy than non-STEMI.
Okay. So the other trial, which is very impressive, is this trial with the omecamtiv mecarbil.
Yes.
So I think the benefit was seen only in patients who had severe ejection, when the ejection fraction is very low. And the benefit was not seen in mild LV dysfunction. Why do you think it is so different in, it probably only in severe patients with low EF?
Well, the interesting thing is we've talked about 4 foundational therapies, and now we've had 2 trials of completely different agents that add some benefit on top. And there was the Victoria trial of vericiguat, a soluble guanylate cyclase stimulator, and omecamtiv mecarbil, and they've both come out in the last 12 months. And they both showed a reduction in composite endpoint of around about 10%. That was significant. Neither showed a reduction in mortality. They both were mainly having benefits on hospitalization. So the community scratched its chin and thought, where would we use these? And an important question, when you get a drug, a new drug that adds benefit on top of everything else, you'd think, well, where would I start? And most people would think of the sickest patients, those with the most frequent hospitalizations, those who are really in trouble. And in that regard, the Victoria trial and Galactic are quite different, because in the Victoria trial, the patients with the highest end-terminal proBNP levels actually didn't do well. And therefore, its benefit weren't seen in the sickest patients. Whereas with omecamtiv mecarbil, it was seen in the sickest patients, the lowest ejection fractions, the highest levels of end-terminal proBNP, those in hospital, those with high NYHA class. And that fits with its mode of action. Its mode of action is to improve cardiac contractility. So the benefit is most obvious in those with very poor cardiac contractility. So personally, I've got a lot of interest in omecamtiv mecarbil because it's the only drug we have that doesn't put blood pressure down. It actually puts it up. It doesn't significantly affect heart rate. And it certainly doesn't cause a reflex tachycardia. And so it could be a very attractive agent in severe heart failure. The other feature in that, which was only a post-hoc analysis, is its benefits were entirely seen in sinus rhythm rather than atrial fibrillation. And there are reasons by mode of action that might be the case, because it prolongs cardiac contraction time. And maybe in rapid AF response, that's not as useful. So I hope that we'll see more trials of omecamtiv to exactly pin down where it's useful.
The other trial, which I was go ahead, sir. Go ahead.
No, I think this is, if this proves to be effective in the long run, I think it will completely satisfy the long-needed inotropic agent. I think it reminds me that years ago, we used to rely a lot on the cardiac glycosides, which would improve the sarcomere contraction, at the same time lower the heart rate, which I think this drug seems to be doing. And the therapeutic dose and the toxic dose for digital, with the margin of safety being very low, it has fallen into disrepute considerably. So this drug perhaps might be very satisfying the need. Like most of the inotropes that we use have a lot of side effects of increased oxygen consumption, increasing peripheral vascular resistance and whatnot, apart from arrhythmia. And all of them are intravenous. So I think something to maintain for the patient with the support to his stroke volume, stroke output, cardiac contractility and whatnot, this would be a suitable agent.
There's a question now about the other trial, but the pirfenidone. Is there any goal for pirfenidone in heart failure with preserved ejection fraction?
That was the trial Pirouette was preserved, because that's the condition where fibrosis is most marked. You do get fibrosis in some cases of HFrEF, and I guess that's a possible target. But I think HFpEF is more attractive because it's more common. It's thought to be more intimately associated with pathophysiology. And of course, there are very few other alternatives. So I think HFpEF is going to be the initial target. But, if it's successful, you never know. Maybe there will be studies of HFrEF.
Okay. Thank you. The other, what I was impressed with, the rehab heart failure trial. I think that's very impressive because, Dr. Mehta, we have been always constraining to have less exercise, particularly in a patient who has severe symptoms of heart failure and to just mild exercise. But this is a very graded training program where they've shown real benefit. So what are your views?
Look, carry on, Dr.
Go ahead, Andrew. Please go ahead.
Yeah, I was going to say, I was very impressed with this. Most trials recruit young patients who aren't that sick and they're pure. These were elderly patients, average of 5 comorbidities. The inclusion criteria is simply that they could walk 4 meters. So they were incredibly limited. 97% had frailty or pre-frailty. They targeted a group that normally would never get into a trial. And they did individualized, early, simple exercises to build up muscle strength and big impact, the biggest effect we've seen on KCCQ. So it's very impressive. And it's an intervention we can all start with our frail elderly heart failure patients literally tomorrow, because We just need a person who can sit there with the patients and teach them how to slowly strengthen their muscle and their balance. I think it's a very practical trial.
And do you think, apart from the skeletal muscles, I'm talking about the myocardium, could there be a contribution of preconditioning or development of collaterals due to graded exercises? How do you explain?
Yes, well, that's always the thing. I mean, many of you might know I've done exercise training and heart failure studies for many, many years. And initially, we thought we'd improve the heart, and there are benefits in terms of, as you say, of revascularization. But a lot of the benefits of training are peripheral. They are skeletal muscle, vascular, reducing neurohormonal, improving autonomic function. It's very hard to know whether there's a separate and important cardiac benefit, but clearly that's possible. We know diastolic function can be improved by exercise training. The heart rate's reduced that can lead to beta blocker-like effects. And there have been some remodeling effects shown in the heart with exercise training. So I honestly don't know the answer to that. I certainly don't exclude useful cardiac benefits, but I think the peripheral benefits are very obvious, and I think that's probably where I put my money as to most of the benefit.
And finally, I think the universal definition of heart failure has made things more clear, and particularly with regard to the BNP in diagnosis. I think that's particularly very impressive to me, because it's one which is very underused, and I think that is now becoming more important in diagnosis of heart failure. Dr. Mehta, your comments?
No, I only felt this way that with this kind of definition, it should not result into comparative inattention to stage 1 and stage 2, like pre-heart failure state. I think the seriousness of treatment should not be diluted because you may consider he is not in the heart failure. No, he is not in the heart failure, but he's in potential heart failure. So the definition should not lead to the dilution of attention towards the pre-heart failure situation.
No, an important point. I mean, clearly there are different recommendations for all 4 of these stages. There are recommendations for risk factors, and they include smoking, hypertension, diabetes, obesity, etc. And certainly there are drugs proven for asymptomatic LV dysfunction, which is the stage B. And then most of our treatments, of course, are for the symptomatic stage, because that's where the big trials have been done.
Thank you, Professor Andrew Coates. I think we had a very informative session. So now let's move to the next part of our session. So I invite Professor Gregory Lipp. So he is going to talk about the recent ACC trials on ACS and preventive cardiology. Gregory Lipp, please.
Right. Thank you very much for the very kind invitation, and greatly enjoyed your talk, Andrew, and nice to see you. So I'm going to be trying to talk a little bit about the anticoagulation studies. Hopefully the slides are coming through. Now, I'm going to focus a bit on being very much a clotting cardiologist. I'm going to be very focused a little bit more on the antithrombotic drugs, but also my other interest in life, which is atrial fibrillation, and as well as I'm just going to cover one of the trials on hypertension. So apologies if this is a little bit of a selected group of trials that I just wish to cover. But perhaps I think the ACC was really exciting in the sense that there are a number of guideline-changing studies that were published or presented. So I'm going to start off with valvular heart disease, and this is a screenshot from the 2017 European Society of Cardiology valvular heart disease guidelines, and this focuses on the table with regard to the antithrombotic drugs, with regard to TAVR, with regard to transcatheter aortic valve intervention. And as you can see here, level of evidence C, because with regard to the use of dual antiplatelet drugs for the first 3 to 6 months after TAVI, followed by lifetime single antiplatelet agents in patients who do not need anticoagulation, single antiplatelet may be considered in cases of high bleeding risk, or anticoagulation considered for the first 3 months after surgical implantation in aortic by prosthesis, but you can see class 2A or or 2B for the latter two recommendations, and all level evidence C. So at the ESC was the Atlantis trial, and this was a large trial looking at antithrombotic strategies in relation to after transaortic valve implantation for aortic stenosis. And this was about 1,500 patients with two stratum. One, stratum 1 with an indication for anticoagulation, stratum 2, no indication for anticoagulation. Stratum 1 was randomized to either vitamin K antagonist, warfarin, or apixaban, a non-vitamin K antagonist oral anticoagulant, sometimes called a DOAC, a direct oral anticoagulant. Stratum 2, where the patients did not have an indication for anticoagulation, they were randomized to apixaban versus antiplatelet drugs. And the primary outcome was the composite of thrombotic type outcomes as well as mortality and bleeding over 1 year of follow-up. So essentially, as I showed on the previous slide, two last guidelines said there was evidence-free zone, and this was a trial really to try and address that. So the primary endpoint of that composite thrombotic outcome, mortality outcome, and bleeding, you will see here in terms of the standard of care compared to apixaban, this was not statistically different at all. And this was also evident irrespective of the stratum, whether in the patients with an anticoagulation indication or those with no anticoagulation indication. If you look at the secondary outcomes, by and large, majority again for the different composites of the endpoints, not a lot of difference at all. There's a hint towards a reduction in bioprosthesis thrombosis, as you can see there. And then there was a reduction in venous thromboembolism in the apixaban-treated patients compared to standard of care. Now, in terms of the safety outcome, as you can see, with regard to the principal safety outcome, which is essentially life-threatening, including fatal or disabling major bleeds, not significantly different, and also the components of the bleeding outcome. But of course, what I've just shown in these slides are for the whole trial. And if you subdivide into a different stratum with indication for or anticoagulation or without anticoagulation, here are the data. So stratum 1, remember, these are the patients with a requirement for oral anticoagulation. And they were, as just to remind us all, they were randomized to apixaban or a vitamin K antagonist. And you will see for the primary outcome, not significantly different at all between apixaban and standard care. Also, all the other outcomes, whether different secondary efficacy outcomes or the safety outcomes with regard to bleeding, not significantly different. There is, as you can see, a suggestion, a trend, but this is not statistically significant, towards a small reduction in the risk of valve thrombosis. What about stratum 2? These are the patients without a need for long-term anticoagulation. And as you can see, not significantly different at all either between apixaban and standard of care. Standard of care in the patients without the need for anticoagulation is largely based on antiplatelet drugs. If you look at the secondary outcomes, really there's a suggestion of actually even a little bit higher in the composite of death, stroke or thromboembolism, a little bit higher in apixaban-treated patients compared to standard of care, and as well as of mortality, and as well as non-cardiovascular death. And valve thrombosis was actually lower. Now, do bear in mind, many of these secondary outcomes. The trial is not adequately powered to fully address those particular outcomes. These are just a signal in one direction, and one can obviously debate: is it important? Is it real? But do note that caution. So in the Atlantis trial, apixaban after TAVR was not superior to standard of care antithrombotic drugs in terms of net clinical benefit globally in the trial or in each of the stratum. The stratum is whether they need an anticoagulation chronically or whether they don't need an anticoagulant chronically. The safety of apixaban was similar to standard care, again in the global trial as well as each of the stratum. There was a reduction in valve thrombosis with apixaban, but although this was driven by the stratum in the patients without an indication of anticoagulation, that's stratum 2. there was a suggestion of mortality in the versus antiplatelet drugs in the patients without an indication for long-term anticoagulation. So you can see what Atlantis tells us, that in terms of standard of care, use of apixaban didn't offer any extra advantage, although there was a suggestion that in subgroups it gives a bit of information what may well be the better option. So clearly, once we see more information coming from the trial, it will help guide us with regard to treatments. So in terms of future guidelines, it's not level evidence C anymore. At least you have some data from this trial. I'm now going to turn to atrial fibrillation, and this was the left atrial appendage occlusion study, LAOS-3. This was also concurrently published in the New England Journal of Medicine. And I think this is a really important trial, but of course I'm a little bit biased on this, given the interest into atrial fibrillation and stroke. And even as recent as the last edition of the 2020 European Society of Cardiology guidelines for the diagnosis and management of atrial fibrillation, and you will go to the section with regard to recommendations for occlusion or exclusion of the left atrial appendage. Left atrial appendage occlusion may be considered for stroke prevention in patient atrial fibrillation and contraindications to long-term anticoagulation. That gets a class 2B level evidence B, because at least there were some trials and there have been some observational or cohort data. And then you come to the next recommendation. Surgical occlusion or exclusion of the left atrial appendage may be considered for stroke prevention in patients with atrial fibrillation undergoing cardiac surgery. Level class 2B, level evidence C. In other words, evidence is consensus. So the LAOS trial, the LAOS-3 trial, actually is a trial specifically addressing that final point. So you will see here the LAOS-3 inclusion criteria: patients with 2 or more cardiovascular risk factors, patients were randomized to no undergoing cardiac surgery, they were randomized to no occlusion versus left atrial appendage occlusion. And there was blinding of patient, research team, treating team, with the primary outcome being ischemic stroke or systemic embolism with the ITT, intention to treat analysis. Safety outcome was hospitalization, particularly for heart failure. And this is the intervention with regard to either stapler or actual amputation or by actually epicardial device closure. And patients follow up for up to 3.8 years. And I think this is important results, because if you look at the primary outcome in 3.8 years, the risk of ischemic stroke and systemic embolism is about a 2/3 reduction in favor of left atrial appendage exclusion or occlusion. And this is particularly evident in the landmark analysis also after 30 days. The Kaplan-Meier curves are shown here. You'll see the 1/3 reduction in favor of occlusion rather than no occlusion. In terms of the secondary outcomes, if you look particularly for the ischemic stroke outcome, this is very clearly driving the secondary outcome, the main outcome at 3.8 years. In terms of other outcomes, systemic embolism, mortality, and heart failure, this was not statistically significant. So reassuring, so basically the message is persuade your cardiac surgeons if they are opening the chest for patients, for these patients with atrial fibrillation and risk factors, take the opportunity to either occlude or exclude the left atrial appendage if their patient is undergoing cardiac surgery. So let's turn now to antiplatelet drugs and peripheral artery disease. And if you look at guidelines which deal with the sort of more chronic management of vascular disease, and this slide is the 2017 peripheral artery disease guidelines from the European Society of Cardiology guidelines. And many of the guidelines do make a suggestion, use aspirin doses, anything between 150 to 300. Now in US, it's 81 milligrams. 75 milligrams to 300 milligrams in many of the European guidelines. In US, they have 81 milligrams and sometimes even higher dose. And one of the trials presented was the adaptable trial, actually asking quite a simple question, because is 81 milligrams or the sort of low dose aspirin better or safer compared to the 325 milligrams, which is the, at least in the UK, is the sort of dose you get over the counter. If you go into any supermarket, if you buy aspirin over the counter, it comes as 300 milligrams. Whereas for some of the prophylaxis of stable vascular disease, some of the guidelines say, well, you should actually try 75 milligrams because it gives the same benefit, but may well be safer. So this is a what's called patient-centric trial, large trial, to try and address this topic. So as you can see, large randomized trial of 15,000 patients with chronic vascular disease, with one additional risk factor, enrichment risk factor, and they were randomized to aspirin 81 milligrams or to aspirin 325 milligrams. And this is, we're going to see more of this sort of trial, that patients will be followed up based on electronic patient follow-up, electronic health records, health plans, and medical insurance data, and looking at the primary outcome, mortality, hospitalization for myocardial infarction, or hospitalization for stroke. And the safety bit, of course, was major bleeding, because the concern is, whether you are taking a low dose of aspirin that is safer, with less major bleeding compared to the 325 milligram dose. Now, the inclusion criteria are patients with vascular disease, whether prior myocardial infarction, revascularization, significant coronary disease, and atherosclerotic cardiovascular disease, or chronic ischemic heart disease. But just to enrich the trial, as you can see, there's one or more enrichment risk factors as summarized on this slide. In other words, just to weight the fact that the patient is going to be an extra risk. There are some exclusion criteria. Obviously, if this is an aspirin trial, if you're allergic to aspirin, well, you can't enter the trial. Obviously, you get a potential for bleeding, which precludes the use of aspirin. And then if there was the current or planned use of an anticoagulant or ticagrelor, and female patients who were pregnant or nursing. So in terms of the primary outcome, all-cause death, hospitalization for MI or stroke, that's the 81 milligram dose curve, and that's the 325 milligram dose. As you can see, the hazard ratio in terms of the primary outcome, not significantly different at all. If anything, the Kaplan-Meier curves actually overlap each other. Now, the bit I was interested to look for was actually the safety bit, because many of us cardiologists say, well, lower is better, you're going to get less bleeding. Well, actually, there wasn't any significant difference between the 81 and the 325 milligrams. So you're getting a similar, in this 15,000 patient trial, similar efficacy outcome, and in terms of safety, this wasn't different either. And here's the primary outcome and the major bleeding outcome. So I showed the Kaplan-Meier curve. And even if you look at mortality, non-fatal MIs and non-fatal strokes, this was not significantly different either. In terms of revascularization, not significantly different. So just to do a summary with regard to adaptable, no significant difference in the efficacy outcome of death, MI, or stroke, comparing aspirin 81 milligrams or 325 milligrams. There was a difference in fidelity to the study. There was, in the higher dose, the 325 milligram dose, there was more dose switching. And this perhaps reflects more the tolerability, because if your patient is more prone to dyspepsia and acid reflux, they may well be more preferred to go on the lower dose. And as I said, the multiple reasons for fidelity was the tolerability, but as well as some other physician and participant preferences. Now, if you go to the vascular disease guidelines that I showed earlier, they largely just talk about antiplatelets with regard to prophylaxis. And of course, it was essentially with the in guidelines in 2017, for example, very limited on dual pathway inhibition with an anticoagulant. And in peripheral artery disease, now there's a hint of this coming from trials such as Atlas and Compass, where dual pathway inhibition with an anticoagulant and an antiplatelet may be beneficial. And at the ACC, this trial was presented. That's the Voyager trial, Voyager PAD. And this was looking at the ischemic events with low-dose rivaroxaban in patients with symptomatic peripheral artery disease post-revascularization. And the trial design is shown here. So just about 6,500 subjects here with patients with peripheral artery disease in lower limbs undergoing peripheral revascularization. They all had background aspirin. They were randomized to either placebo or rivaroxaban 2.5 milligrams BID. So this is mini dose rivaroxaban twice a day. This is not the recommended stroke prevention dose for atrial fibrillation. So do bear in mind that this is mini dose BID rivaroxaban. And they were therefore followed up with a primary outcome of time to first acute limb ischemia, amputation, myocardial infarction, stroke, or cardiovascular death, essentially sort of cardiovascular thrombotic type outcomes. And the safety outcome was major bleeding. So Voyager PAD, the primary results are shown here. For the primary outcome, as mentioned before, this is the composite of various thrombotic type outcomes. The red is placebo, in purple is rivaroxaban. You can see this reduction by about 15% in favor of rivaroxaban treated patients compared to placebo on top of aspirin. So dual pathway inhibition does reduce the composite thrombotic outcomes. In fact, the NNT number needed to treat to show this benefit is 39. 15% for this 15% reduction. The downside is here, major bleeding, TIMI major bleeding, and this was an increase in 43%. Number needed to harm 125. As you can see, the event rate goes from 1.9 up to 2.7. Now, there are secondary outcomes. This is unplanned limb revascularization. And as you can see, the rivaroxaban arm significantly lower compared to the placebo arm, 12% difference in favor of rivaroxaban. If you look at venous thromboembolism, no big surprise, these are patients also who do better on an anticoagulant, a 39% reduction in favor of rivaroxaban compared to placebo. So this forest plot shows the conventional intention to treat versus time-varying rivaroxaban exposure. In other words, a sort of on treatment if they're actually taking the drug. And no big surprise, if you're actually taking the drug, patient actually does better compared to the conventional reporting of clinical trials with an intention to treat. This is for the primary events as well as the total vascular events. What's the take-home message from Voyager? Well, peripheral artery disease patients undergoing the lower limb revascularization, they are high risk of adverse limb and cardiovascular events. And even despite current medical therapies, which are largely based on antiplatelets. The concern is, of course, the major adverse limb outcomes. And what Voyager tells us is that dual pathway blockade, rivaroxaban 2.5 milligrams BID plus aspirin versus aspirin alone, a significant reduction in first and subsequent limb events and cardiovascular events, and also a greater total benefit if you're considering all the events. So this is clearly adjunctive therapy after lower extremity revascularization to reduce thrombotic and cardiovascular outcomes in patients, and very likely to be another guideline change in clinical trial. Now, let's move to antiplatelet drugs. And this is from the dual antiplatelet therapy guideline focus update from 2017. And I flagged this up because what happens is that in many countries and many clinical practices, there's very in patients with syndrome, there's a lot of and revascularization. Very often, aspirin plus ticagrelor is becoming increasingly used. However, in some healthcare settings, ticagrelor may be used for a while, but swapping to clopidogrel instead of ticagrelor is sometimes done. But in 2017, when this guideline came out, you will see the switching may be considered in times of side effects or drug intolerance, but you'll see it's a class 2B recommendation with a level of evidence C, in other words, consensus. So this was another evidence-free area. The other way around, from clopidogrel to ticagrelor, there is a little bit of data from this. This therefore gets a class 1 recommendation, level evidence B. But so in other words, what I'm really saying is if you've got a patient started because of the acute coronary syndrome on aspirin, ticagrelor, what's the evidence with regard to changing to aspirin plus clopidogrel? And one of the trials at the ACC was TALOS AMI, which was stabilized patients with acute myocardial infarction and comparing basically ticagrelor versus de-escalation to clopidogrel. And the trial design was here. So if there are patients with a successful acute myocardial infarction, patient with a successful PCI, aspirin ticagrelor, as I mentioned before, is quite commonly used. And after about 30 days, they were randomized to de-escalation to aspirin clopidogrel, or to continue with their aspirin ticagrelor, and patients were followed up to 12 months. So in terms of the composite outcome of cardiovascular death, myocardial infarction, stroke, and bleeding, you will see that the active arm, which is, remember, as I said, is aspirin, continuing aspirin plus ticagrelor versus de-escalation. There's a clear reduction in the composite outcome here. And this difference is largely driven by the difference in bleeding, as shown on the right here, because the active control arm, in other words, aspirin plus ticagrelor, versus those de-escalated to aspirin plus clopidogrel, there's a 48% reduction in serious bleeding events. In terms of the cardiovascular outcome, the composite of cardiovascular death, myocardial infarction, and stroke, this was not significantly different at all. So this is a bit of evidence-based now and reassurance that in acute myocardial infarction after PCI, if they've had no adverse events in the first month after the PCI, uniform unguided de-escalation of a DAP strategy, switching from ticagrelor to clopidogrel, was actually superior to continuing a ticagrelor-based DAP strategy, particularly driven by the reduction in bleeding. There was no appreciable difference in the ischemic or thrombotic risk there. So there is now some evidence to be able to guide us now that, that after the initial period of 30 days of aspirin ticagrelor, we can change them or de-escalate to aspirin plus clopidogrel without a difference in ischemic risk, but a clear reduction in bleeding. Let's turn now to hypertension, 2018 ESC guidelines. And if you look at the section of recommendations of device-based therapies, it says use of device-based therapies is not recommended for routine treatment of hypertension unless in the context of clinical studies and randomized trials. It's class 3 recommendation, level evidence B. And there's a bit of text here. Major uncertainties remain as to the clinical role of renal denervation outside of clinical studies, which should be performed in carefully selected patients at specialist centers. And in the ACC, there was the Radiance Hypertension Trio trial, and it was randomized and a sham controlled. These were patients with hypertension resistant to triple medications. And the trial design is shown here. So they had to be hypertensive on 3 antihypertensive drugs, yet still uncontrolled. And the clear sort of workup to ensure that they don't have secondary hypertension. There's no recent cardiovascular or cerebrovascular events, no diabetes. Renal function was also satisfactory, and a legible renal artery anatomy. And with that in mind, after appropriate workup, they were then randomized to sham procedure or renal denervation. And the primary outcome was looking at obviously blood pressures at 2 months and the differences. There were no medication changes unless there was the blood pressure really was exceeded, and patients were blinded at randomization. In terms of the outcomes, primary efficacy outcome was 2 months with a daytime ambulatory systolic blood pressure, 6-month follow-up, 12-month follow-up as well, with the unblinded and standard care medications. So in terms of the intention to treat population, it's not a huge trial, but for the renal denervation arm compared to the sham procedure, as you can see, a clear difference between the groups, a median difference of about 4.5 millimeters of mercury, which is statistically significant. This is on the ITT analysis. If you look at the ambulatory blood pressure monitoring, you will see here again, in terms of the group difference, about 5.8 millimeter difference in favor of the renal denervation compared to the sham procedure. What about office and home blood pressures? This is systolic blood pressures again. You see the same trends, 7 millimeter difference in favor of renal denervation compared to sham. Home blood pressures, you see a difference of about 4 millimeters in favor of renal denervation compared to sham procedure. So I think RADIANT's hypertension trio, it does suggest that resistant hypertension patients where despite their being on guideline recommended triple therapy, this ultrasound-based renal denervation was associated with a better reduction in systolic blood pressure compared to a sham procedure. And that was consistent whether looking at 24-hour, nighttime, and office blood pressure. These results are consistent with RADIANT's hypertension solo, which was a group of patients with mild to moderate hypertension. Obviously, we need longer-term efficacy and safety outcomes. Now, I'm going to finish off with a couple of trials presented at ACC related to COVID, because this is obviously a very topical area. The trial one slide has gone out of sync. Anyway, I want to present the ACTION trial. This was a trial where patients who were hospitalized with COVID with a high D-dimer at admission were randomized to standard of care, in other words, prophylactic dose anticoagulants versus therapeutic anticoagulation. Now, therapeutic anticoagulation is given either as in-hospital enoxaparin at therapeutic dose, or in the stable patients where they could take, obviously, oral, they were given rivaroxaban 20 milligrams. And the primary outcome, as you can see, hierarchical analysis, mortality, hospitalization, and duration of oxygen use. So, the ACTION trial, the primary outcome is shown here. So comparing the prophylactic arm, which is the conventional or usual care, and the therapeutic arm, as I mentioned, either therapeutic dose heparin or rivaroxaban 20 milligrams, you see this was not statistically different in terms of the 30-day mortality. If you look at the safety outcomes, the therapeutic arm, so rivaroxaban 20 milligrams or full dose enoxaparin compared to prophylactic usual care treatment, there's a 3.64 excess risk of composite major or clinically relevant non-major bleed. And you will see it's largely driven by a significant difference in the clinically relevant non-major bleed, although the trend is clearly there also for the major bleeds. Any bleeds, of course, is higher with a therapeutic anticoagulation arm compared to usual care. The net clinical benefit is not statistically significant, although the trends obviously for higher in the therapeutic intervention arm. So in the patients hospitalized with COVID, with elevated D-dimer, the therapeutic anticoagulation regime did not improve clinical outcomes, but instead increased bleeding risk. Now, why is anticoagulation important and in the setting of relation to various comorbidities, cardiovascular comorbidities? And I think this is something we all recognize, because this is a slide which summarizes a Public Health England systematic review and evidence appraisal that I think this is hopefully reasonably familiar to most of us, that the patients who have associated cardiovascular disease, they are 3.9-fold higher odds of severe COVID, and they have a 2.7-fold higher risk of mortality. And that is evident for hypertension, evident for obesity, evident for diabetes, for cerebrovascular disease. Smoking increases the risk of developing severe COVID, and this relates to the thrombotic outcomes. Just to direct the interested folks to the very recent review of this in the Lancet Hematology, because they're stage 1, those who have ambulant patients and who have very mild disease, the thrombotic risk is low, and these patients may have very limited thrombotic outcomes. We then have the hospitalized patients where there's the increased inflammation and coagulation abnormalities, and thrombotic events the risk is higher. Stage 3, of course, the patients who are critically ill in the ICU. There's really a cytokine storm and inflammatory overload leading to complete coagulation derangement and increased risk of thrombotic outcomes. And of course, we have the post-discharge group with the increasing recognition of long COVID rather, where the coagulation and inflammation are largely restored, but the thrombotic risk is unknown. So no big surprise, there's a number of ongoing anti-thrombotic therapy trials, anticoagulant trials in these group of patients. And so I showed before the ACTION trial, which was focused obviously on one of the DOACs, the direct oral anticoagulants there, and a number of trials are whether in outpatients, in the hospitalized patients, the not ICU, of course, then the post-discharge as well. And these are different trials of different settings. I talked a little bit earlier about Voyager. I just want to flag up this trial, C19 ACS, and also its dual pathway inhibition with low dose rivaroxaban plus aspirin plus clopidogrel compared to usual care to try and reduce the adverse outcomes in COVID patients. However, at the ACC, continuing the story about COVID interventions, the Inspiration S trial was presented, and Inspiration S is the statin arm of a 2x2 factorial design trial. The anticoagulant trial was published at the end of last year, where these were patients randomized to intermediate dose heparin, enoxaparin versus standard dose prophylaxis. And as you can see, in terms of the primary outcome, there was no difference between intermediate dose and standard dose enoxaparin. But the problem is here, major bleeding occurred in 2.5% of the intermediate dose patients compared to 1.4% in the standard prophylaxis dose. Therefore, no difference in no beneficial efficacy outcome, but there was more bleeding. So Inspiration was a 2x2 factorial design. This was the heparin arm randomized to standard versus standard prophylaxis versus intermediate. Then the next strata was Inspiration S, which was randomizing patients to atorvastatin 20 milligram versus placebo. So why atorvastatin? Because we all recognize for many years now statins having pleiotropic effects and reducing inflammation, reducing thrombosis, etc. So this trial was presented, and you will see here the primary efficacy outcome of Inspiration S, atorvastatin versus placebo. This was not statistically significant. There was a hint, it was a slight reduction, but this did not reach statistical significance. If you look at the safety outcomes, particularly for bleeding, again, all of this was not statistically significant. So Inspiration S is the first of a whole number of statin trials in hospitalized ICU patients with COVID. Other trials, as highlighted on this table, are yet to report, but Inspiration as the first of these trials suggesting that statins, whilst theoretically they may be a benefit, there wasn't any significant benefit. Just to finish off with dapagliflozin in patients hospitalized with COVID, this was the DARE-19 trial, which was presented at the ACC. And to keep a long story short, these were hospitalized patients with COVID randomized to dapagliflozin versus placebo. And the patients would follow up to 60 and 90 days over this time period, the DARE-19 trial. In terms of all-cause mortality, there was a hint, but this was not statistically significant at all between dapagliflozin and placebo. For time to organ failure or death, again, not significantly different between the intervention arm and the placebo arm. Numerically less with dapagliflozin, but this was not statistically significant, although dapagliflozin was reasonably well tolerated. Now, we are obviously this is a pandemic where every month there are new advances. And as regard to the role of antithrombotic drugs, we're dealing with thromboinflammation. And you will see this diagram here with all the potential pathways that require interventions in the setting of COVID infection, from very mild going on to obviously severe and hospitalized in ICU. So this is a rapidly evolving field, and there's no doubt we'll get more information over the coming months and years. And I very much hope things will obviously get better for all of us with regard to this therapeutic area. And with that, thank you for your attention. And this was a general flavor of what we had presented at the ACC. And I think what is really nice is some of them are truly guideline-changing clinical trials. And with that, thank you for your attention.
Thank you very much, Dr. Lip. It was a very interesting trials, very interesting presentation. So let's discuss about each of the trials. So we'll start with the first Atlantis trial, which you said. So again, that's a very interesting trial. I think there was a lot of hope on using these NOACs in post-TAVR, but I think now it's clear from this trial that I think we cannot routinely use. But if you take it the other way, apixaban is quite safe and to give post-TAVR, even compared to standard anticoagulation, patients who require anticoagulation. Those patients, instead of standard anticoagulation, vitamin K antagonist, we can give apixaban, which is probably safe. That also can be taken as one of the inferences from this trial. And secondly, compared to antiplatelets, it's very clear that apixaban is not going to add more benefit, except that we have seen reduction in valve thrombosis, but that has not translated to clinical benefit. I think we need more data to see whether really by reducing the valve thrombosis, are we really giving some clinical benefit. So I think that's a very important trial which you've learned. There is a question from the trial regarding the Atlantis trial. Let me see this question.
You make very valid points, because this is the second NOAC trial as Galileo with the rivaroxaban, and that didn't show any sort of compelling advantage either. So I think at the moment with TAVI patients is what we're doing seems to be right so far, as opposed to trying to bring in the NOAC.
So there's a question: is 1 year enough to evaluate the difference, especially in the stratum 1?
Well, I think compared to the situation a few years ago where it was an evidence-free zone, I think we do have, with a reasonably large enough study to show that at 1 year, there really wasn't enough information. There wasn't enough evidence to in favor of using a NOAC. So is it enough? I think it's enough evidence. Bear in mind that a couple of years back, we didn't have any evidence for the use of NOACs in this situation.
Yeah, there's another question. How do you explain the difference in subclinical valve thrombosis But I think in the oral anticoagulation arm, where they compared vitamin K antagonist versus apixaban, there was no difference in valve thrombosis, which clearly says both anticoagulation arm really helped in reducing valve thrombosis. But in the other standard of care, that is antiplatelets versus apixaban, there was definitely much less valve thrombosis in the apixaban group. Again, it is very clear because of the anticoagulation, there is less valve thrombosis.
That is true, but in terms of absolute number of events, we're talking quite small numbers. But even if there was that at least statistical reduction in the small number of valve thrombosis events, overall there wasn't any sort of benefit on the heart clinical outcomes for the overall population. So we have to bear this in mind. We can focus on an outcome or be selective in an outcome looking for the benefit. It's no big surprise an anticoagulant will be better at reducing valve-related thrombosis than aspirin or something like this, but didn't make a difference in long term.
Dr. Mehta, you make any comment?
No, thank you.
Okay, so let's move to the next trial. I think LAVOS 3. I think that's a really interesting trial because many of all these years, we have been using the appendage closure. Surgeons have been closing the appendage, left ventricular appendage, but without much of data. So I think now we have some kind of data which says closing the left ventricular appendage is beneficial for those patients going for cardiac surgery. But the other thing is the benefit of having the left ventricular appendage. We know that there's a rich source of atrial natriuretic peptide, and maybe losing the left ventricular appendage whether can lead to more episodes of heart failure. That is one of the concerns probably addressed in this trial, and it did show some increase in heart failure admissions. Dr. Lip?
We're talking less than 1% difference, and this was really not materially different. So compared that to a devastating stroke or a systemic embolism, I think looking at a number of endpoints, I think this is still very much in favor. If the chest is open, ask our cardiac surgeons to have the opportunity to either exclude or occlude the left atrial appendage.
Dr. Mehta, I think most of our surgeons have been doing this for a long time, for decades. What do you feel?
Without evidence, I should say.
I will. Singh, I'll give you an analogy. To me, the left atrial appendage and the appendix, both are vestigial organs. And, for years together, abdominal surgeons have been practicing to remove appendix if it can be easily accessible while doing a non-appendix surgery, like, let's say, hysterectomy, abdominal hysterectomy, or ureteric surgery, and the appendix is just nearby, remove it. And so that patient can never get an appendicitis ever in any lifetime. So to me, I think if there is an opportunity to remove the appendix, the left atrial appendage, I think.
Last year said level evidence C. Well, we have to change that now.
So there's a question. In this registry, a Watchman device has been used. Please share some details about this device. Was it used?
For the allows, this was patients actually randomized to the left atrial appendage occlusion or exclusion. And I think if I just share my slide very quickly again, this was how the interventions were either stapler occlusion, amputation or with surgical closure, or epicardial device closure. You see this little clip type thing. So it's not really a Watchman here, as not according to what was presented.
Yeah, I think it's basically surgery, during cardiac surgery. So it's not a catheter intervention.
Yeah. Okay. So there were patients undergoing
catheter intervention.
Yeah. Okay. So there were patients undergoing cardiac surgery when, as Dr. Mehta says, basically that the chest is open.
That's again interesting trial. I think there was some interest in this low-dose rivaroxaban in the COMPASS trial. And we know that the more the risk factors are with multiple risk factors for vascular disease, this really helps. Low-dose rivaroxaban helps. But I was only wondering, why was it compared to aspirin alone? The comparative arm was aspirin alone. It should have been a standard of care with aspirin and clopidogrel, do you think? Or DAPT?
So the trial design is shown here. Oops, hang on a second. So if you look at this was the aspirin and clopidogrel at the investigator discretion. So some of the patients did get clopidogrel. But remember, that's the standard of care, which is either aspirin or aspirin plus clopidogrel, depending on the sort of, you could say.
So so you get one arm. There is a possibility of both aspirin, clopidogrel, and rivaroxaban, and that kind of a bias could be there because of the multiple drugs involved in this trial.
But despite that, the dual pathway inhibition, blocking platelets and also blocking the sort of low dose of factor Xa inhibition actually conferred benefit.
So, what do you think? How do we interpret this trial results particularly in relation to coronary artery disease? Because now there are guidelines which are recommending low dose rivaroxaban for those patients who have polyvascular disease, particularly after the DAPT. So probably it adds more kind of indirect evidence to give more of low dose rivaroxaban.
I think Voyager is very supportive and consistent with COMPASS and ATLAS, because when patients with in the long term after ACS with high risk or those with polyvascular disease, as you refer, and they get thrombotic outcomes, it's not just platelets, because there is fibrin as well. So if you actually block not only the platelets, but also block the generation of fibrin or thrombogenesis with a low dose rivaroxaban, you get extra benefit. But the extra benefit does come with a small cost, because the major bleed rate is also increased. So you have to make sure that you select your patients appropriately, where the net benefit is clearly in favor of dual pathway blockade.
I think that's an important message, and you need to weigh the ischemic risk versus bleeding risk and plan. But this rivaroxaban low dose is really promising in younger patients who have low bleeding risk. So,
Sangatwelu, one more question. I think it's just not connected with the peripheral arterial disease or so, but we have a very sticky problem, and that is coronary ectasia. A profound degree of coronary ectasia is purely a medical condition. And at times there are problems, and I wonder whether in association with one of the antiplatelet drugs or just purely alone, one could use a low molecular weight heparin, like things like rivaroxaban in small dose. You have any thoughts about it?
It's very interesting. I think we don't have data, but I think these are the patients who have, if the bleeding risks are low, probably these are the subsets who will benefit with low dose rivaroxaban. What do you think, Dr. Lip?
I think that's reasonable. I mean, even for before intervention strategies became very more widespread, patient comes in with a diagnosis of acute coronary syndrome, or in those days, unstable angina. We gave them aspirin, and we gave them also anticoagulation with heparin. We gave them calcium blockers, beta blockers, and nitrates as well. This was all trying to throw the book at them with all these to try and minimize the potential risk of these patients. So things have evolved much more. We're now in the era of much more interventions, and we recognize now dual pathway blockade seems to be beneficial. So yes, this is how the therapeutic armamentarium changes over time.
Yeah. So can we move to the next trial? Okay. Yeah. So the TAVROS AMI, I think, is very interesting again, and particularly in our context. we always want to de-escalate. We want to give ticagrelor and maybe change it to clopidogrel and aspirin after about 3 months or 6 months. Although we didn't have data, we've been doing this for quite some time. But I think this trial has clearly shown de-escalating at 1 month has shown benefits. De-escalating from ticagrelor to clopidogrel really shown benefit. I think it's practically very useful for us as interventional cardiologists. So Dr. Mehta, your views?
Well, I have a little different thoughts. I feel that this is why are we so averse to the use of ticagrelor? Ticagrelor is not a prodrug. Ticagrelor is reversible binding. Ticagrelor, when you discontinue for any elective surgery to come in future, just 48 hours is more than enough. All these things, benefits are there. And not only that, but the ticagrelor has proved to be more effective recipient inhibitor and reception inhibitor. So therefore, there is no mention of using ticagrelor alone. We talk of using aspirin and clopidogrel. Now,
True.
we also know that there is some data that the clopidogrel resistance could be as high as 45% of the cases. So without your knowledge, for all that you know, you might be using aspirin alone in your cases. Who knows? We do not routinely do the thromboelastography, or we do not routinely do the platelet inhibition studies. So the people who have been receiving aspirin and clopidogrel together might be actually getting only aspirin from practical point of view. In that respect, no resistance has ever been described to ticagrelor. So I would prefer to use ticagrelor alone after 3 months. In a smaller dose, maybe 60 twice a day.
No, that's absolutely with the TULIGHT study. I think it's interesting, and we can probably give a single antiplatelet agent with ticagrelor. But what is interesting in this Dallas AMI is they have found after 1 month, they have switched over from aspirin ticagrelor to aspirin clopidogrel. They have seen there is a reduction in bleeding and the same ischemic benefits. Net benefit is the same, but they have a lower risk, bleeding risk, which is very interesting when you can de-escalate safely, which is not, we didn't have any data before to reduce, to de-escalate after 1 month.
But there will be one problem, Singirvelu. If there is a semi-elective surgery popping in, then I think clopidogrel will require 5 to 6 days of discontinuation as compared to ticagrelor. So there are certain downside to that also. That was the point. And the second question is, how do you do? Do you use any algorithm that you reload them?
Yes.
What do you do?
Dr. Lip, did they reload it after 1 month? It's very interesting. We should have reloaded it 300 milligram of clopidogrel.
Yeah, I think they did. We have to look at the actual trial protocol, but yes, the answer is that the reload is as a one-off. Yes.
On the
each arm is only about 69 patients, so you need to see more data.
Interesting trials on COVID patients. I think that's really interesting. So the ACTION trial, I think there was a question: rivaroxaban versus prophylactic difference in between the high dose rivaroxaban and regular 20 milligram rivaroxaban versus mean. How much dose did they give for the prophylactic?
Well, prophylaxis or with low molecular weight heparin compared to therapeutic dose, and in this ACTION it was tested either full dose enoxaparin, or if they are not unstable, in other words, not ICU, they got rivaroxaban 20. So if the question in the chat box relates to if you gave a lower dose rivaroxaban, will it help? Well, the answer is we don't know yet. There are ongoing trials.
So there's a question on ACTION which says, do you recommend prophylactic administration based on these results?
It's going to be beneficial, but whether a reduced dose rivaroxaban as part of dual pathway inhibition is going to show any benefit or whatever, that remains to be seen.
So finally, I think the Inspiration S trial, the DAR19, of course, didn't show any benefit with either statin or with the SGLT2 inhibitors. I think there's too much of expectation that the statin is going to do wonders in COVID. So I think these were all negative trials. I think it was interesting during these periods of COVID. So I think overall it was a very interesting number of trials which we discussed now. Dr. Mehta, would you like to add something more?
No, nothing.
So any further questions? Anything more to discuss? Otherwise, I request Dr. Mehta to give the concluding remarks and close the session. And I'd like to thank Dr. Lip. I think we had a wonderful session. Thank you, Dr. Lip.
Delighted. Thank you very much.
I think we are greatly indebted to Dr. Lip and Dr. Coates for they have spent such time with all of us. I think about 1,000 and odd people benefited from their talk because they really, it was a brainstorming. I think it was wonderful. I think not only they presented these new trials or whatever new data that came in, but they were very ready to discuss the pros and cons of every aspect of the trial that was presented there. And therefore, this, I think, was really a thorough and deep study of each and every trial which was analyzed in front of us so that we can take legitimate conclusions and then add it to our practice. What do you say, Dr. Singatwelu?
Absolutely, sir. We had a very good time and a very interesting discussion. Thank you very much for that discussion, Dr. Lip and Dr. Coates. Yes.
Okay, and thanks to Lupin for all.
Yeah, thank you, Dr. Gregory Lip, Dr. Ashwin Mehta, and Dr. Singatwelu for sparing your time and be on our platform to discuss the celebration of science of ACC. Thank you very much to all of them, and I look forward to meet you in some time when there is a relaxation in the norms of the government. Thank you, sir. Thank you very much to all the viewers also.
Thank you.
Bye. Stay safe. Bye.
Bye.